So thank you very much for the organizing and me for inviting me to give this talk. It's kind of a difficult task to follow the footsteps of the Olympus on the genetics of mitral valve, and then two very distinguished speakers. But it's a very hot topic, I said, and it was one of the major clinical trials that was presented in the last week's American Heart Association meeting. So thank you for inviting me. So I'd just like to while we're doing this presentation, start with a case presentation that we all deal every day. It's a very down to the earth. So this is a case we operated at Hadassah. It's a 67-year-old male who actually presented with class 4 symptoms of heart failure. He didn't have any history of heart disease, but he has a history of hypertension and insulin-dependent diabetes mellitus. Because of his class 4 symptoms, he was seen by a heart failure cardiologist in the community. He was sent for cardiac catheterization, and cardiac catheterization showed 3-vessel disease, and the echo showed severely reduced LV infarction and severe MR. EKG, I didn't show the EKG, showed old anterior septal MR. And you don't have to be a cardiologist, a very experienced echocardiographer to see that this patient has basically ischemic cardiomyopathy. He had anterior septal MI with thinning of the anterior septum and the apex, and tethering of the mitral valve leaflets with severe ischemic MR. So what do we do with it? So ischemic MR is a very complex disease, and here in the room are some of the more prominent investigators that many of them are in Israel, collaborating with a group in Boston, Ronen, Chaim Yosefi, Dan Gilon, and many others in Israel who've looked into this issue. But we mostly think about it as a disease when there is a posterior inferior myocardial infarction with areas of ischemia and distortion of the posterior wall, sometimes dyskinetic or aneurysm, causing a displacement of the posterior papillary muscle, tethering of the mitral valve leaflet, and severe ischemic MR. But this is a work from Yosefi and the group, and you can see that it's also as a consequence of anterior wall MI, particularly with poor apical segments, and that can cause the same problem with tethering of the leaflets and causing severe MR. It's a very complex disease. It's not just tethering and displacement of the papillary muscle, but there is also reducing or increasing, depends on the synchrony of the closing force of the mitral valve, and multiple factors are involved, and therefore how to treat it is very complex. But one thing for sure, ischemic MR is a bad disease. The prognosis is grave. I'll just show you two series. There are multiple series like this. Is one study from circulation by Grigioni on more than 700 patients. So the patients with severe MR, ischemic MR, they die. There's no question about it, and it's a bad disease. This is another series that looks at the relationship between survival and patient with 400 patients with severe MR after myocardial infarction. And you can see that not only they died, even if they have mild MR, this is, you can see on the two bottom panels, that if you have even moderate MR or mild MR, this has an adverse effect on survival. And the odds ratio of dying versus not is 2.2. So you have more than twice likelihood of hazard ratio to die from after on the long term if you have MR versus if you did not have. So I'm not going to elaborate more on the disease because there are much more experts on this, but what should we do with it? And I must say that when you look into it and you look at it as a surgeon, you become very unhappy because neither mitral valve repair or replacement are not an optimal solution. And that's very simple because we are looking at a solution that is based on the mitral valve area, either repair using an undersized ring or other repair techniques that I will elaborate, or mitral valve replacement, and we are treating a myocardial disease. So therefore, we are really unable to impact survival. So we are unable to impact survival, and there is question on impact on LV remodeling and impact on heart failure and other cardiac-related events. Nevertheless, mitral valve, in line with our enthusiasm as surgeons, we just heard about treating asymptomatic patients with organic, in this case, degenerative disease of the mitral valve when they are asymptomatic. So we really like repair, and there are multiple reasons to think, because on an ischemic MR, the basic technique is undersized ring. It's technically easy, it's very reproducible, it enhances coaptation surface, and most importantly, it preserves the mitral valve apparatus, and therefore we hope that it will preserve better the global LV systolic function. There are caveats to repair though. One is mitral stenosis, and we don't think about it because we take patients with a normal valve and we're actually making them smaller. Is it important or not? And the real question is the durability of the repair, because we treat again the valve, but the problem is in the myocardium. So I've just put one study on that. This is a study published in JTCVS in 2014, and they took 70 patients with matched post-myocardial infarction ischemic MR, 35 ED rings, and 35 ED mitral valve replacement. And as you can see on the top, you can see that this top panel, the top two panels, you can see that they have essentially, when they get rest, you don't see much. But when they exercise, there is a significant amount of mitral stenosis, and that impairs the functional capacity. The durability is the more important problem. This is from a meta-analysis published by Magne in cardiology in 2009, and what we can see is very worrisome results of mitral valve repair using annuloplasty ring. If you just look at the even 10 days or 30-day outcome, you should expect that people who are leaving the hospital 10 days post-op, and definitely 30-day post-op, will have in the range of 20% recurrent or residual mitral regurgitation after undersized ring repair. If you look 1 year later, that's where the inch point, and you can see that it rises exponentially, and 5 years post-op, in this meta-analysis of more than 7,000 patients, 80% of patients will have recurrent MR. That's very worrisome. You don't have an operation that would last less than 5 years, or 20% would have disease that will actually stay the same or within 1 month post-op. So what are the advantages of mitral valve replacement? One is definitely it cures the MR. There's complete elimination of mitral regurgitation, and the results are durable, but you pay a price. One, almost invariably, you have to sever some of the chordae and interrupt the subvalvular mechanism. So there is a change in the LV geometry and impairment of the global LV function. And there's all the issues that are associated, because most of those patients, given their limited life expectancy, most of them would receive tissue valve, and the tissue valve will deteriorate, either by calcification, panels formation, wear and tear of the leaflets, and endocarditis and other causes. But nevertheless, if you look at the early series, and that means 90s and early 2000s, most people, given the potential advantages of mitral valve repair, did more repair. So I just put in 2 series. One is from Eugene Grossi from NYU, that shows here. And that shows that indeed mitral valve repair early results, and you see it's 223 patients, 2/3 at what mitral valve repair using undersized ring, and they indeed enjoyed earlier outcome. If you look at this is a multivariable analysis, and you can see that the odds ratio of 30-day mortality and morbidity was 2/3. So they enjoyed the outcomes of mitral valve repair on the 30-day outcomes was much better. But as expected, long-term survival in this series, and they had follow-up up to 10 years, was not significantly different, although the odds ratio was 0.75, but the confidence intervals show that the outcomes of repair and replacement in terms of survival were no different. This is another study, this one from the Cleveland Clinic, on close to 500 patients. Again, you see the vast majority of patients received mitral valve repair because we thought that undersized ring is a good repair. And on those patients, first of all, the anti-assist, we've seen again that ischemic MR is a bad disease. 7-year follow-up, 50% mortality. So no matter what you do to them, 5 years later, half of the patient will die. But if you look very carefully again, you look at the repair versus replacement, you see that in the low-risk categories, there is no difference. Only in the very high, and they have a different score, they grade it into 3-4 categories. I'm not going to elaborate on that. Only in those categories you see some advantage of mitral valve repair. But then come the CTSNet. Because all of those were retrospective, registry-based trials, there was a need for a prospective randomized trial that was initiated by the Cardiothoracic Surgery Network. And last week they presented a 2-year outcome, which essentially were the same as the 1-year outcome, but even worse. And those results were published in last week in the New England Journal of Medicine. And if you look at the study population consisted of 251 patients, 126 were randomized to receive undersized annuloplasty, and 125 received mitral valve replacement. In terms of the operative technique, they received the state-of-the-art. So they used annuloplasty that was a semi-rigid or rigid ring, and it was a complete remodeling ring, as opposed to previous operations were done with a flexible or bands, incomplete bands. And the mitral valve replacements, 98% of them, it is important, were caudal sparing mitral valve replacement. So they only severed some of the anterior leaflets, called and preserved the entire posterior leaflet, and most corded to the anterior leaflet. And you can see on the left-hand panel that the time event to death was not substantially different after 2 years. There was no difference in survival. There was also no difference in the composite endpoint of death, stroke, hospitalization for heart failure, and mitral valve reintervention. No significant difference. There was a significant difference only in one thing. Again, if you look at the LV remodeling, which was the primary endpoint, the LV and systolic volume index, there was no substantial difference. There was no substantial difference in left ventricular ejection fraction. So our hope that mitral valve repair will preserve LV function and improve LV remodeling did not happen after 2 years. But there was a substantial and significant difference with a p-value of less than 0.1 in terms of recurrent MR. There was a tiny but important difference in clinical outcomes. You cannot see this again, but just focus on 2 red bars. The mitral valve replacement group benefited from the operation. They had less heart failure, and this was significant, and the rate for readmissions with cardiovascular events was less with mitral valve replacement rather than repair. So what are the predictors of mitral valve repair failure using an undersized ring for ischemic MR? Are we doomed to fail in anyone? And there is a very good study published by Irving Krohn in the JTCVS last month, and they divided into clinical factors and echocardiographic parameters, which are quite intuitive. The most important clinical factor is the location of the myocardial infarction, whether it's inferior wall dyskinesia or anterior wall, as we just presented earlier, advanced age, advanced New York Heart Association, and prior CABG or PCI. All the echocardiographic parameters are focusing on LV geometry and mitral valve geometry. And these are some of the factors that we should look, and we should ask our cardiologists and imaging cardiologists to give us the information if we would consider to do mitral valve repair. So we look at all the signs of advanced LV remodeling: LV size, mitral valve tenting area, as you can see here, tenting height, the leaflet angles, the anterior and posterior leaflet angles. All those, if we want to consider even mitral valve repair in this setting, should be provided to us and be factors if we decide to choose between repair or replacement. So this is the most common form of failure after undersized ring. It's progressive tethering of the leaflets. And one can see the undersized ring in this view. You see the central MR, and you can see the severe leaflet tethering that is progressive. And once you have MR and you have progressive geometrical changes, furthermore LV dilatation, the tethering progresses, and that's how the repair fails. From a surgical perspective, although I look into all this and I actually measure all those before I decide to do it, I think the number one measurement to remember, and this is an important measure, is the LV end systolic and diastolic diameter. This is a very strong predictor. And the LV end diastolic diameter of 65 almost ensures that you would fail with undersized ring repair alone. And this is a study from Robert Young's group from Belgium, and you can see that if you have patients with ischemic MR and the LVN diastolic diameter is greater than 65 millimeters, less than 65 millimeters, your likelihood to have a sustainable good result is, over a period of 6-year follow-up, is at 90%. Whereas if your diastolic diameter is greater than 65 millimeters, you are doomed to fail with very similar rates to what has been published earlier. So should we abandon mitral valve repair for ischemic MR? Are we going to go to hell, as Dante? And I say no. And I think we should look into advanced technique of mitral repair for ischemic MR. And there are at least 3 categories, but we don't employ too often, and some of them are in a very early beginning of using them for this specific setting. One is division of the secondary chordae. Second is papillary muscle reapproximation, and anterior leaflet patch augmentation, which we do very often for other diseases. And this is how it looks, and this is the rationale. Most of the tethering occurs using secondary chordae that's being stretched. If we sever them, we can probably help the patient. And although it's almost counterintuitive to cut chordae and expect improvement of the MR, this is a completely different concept than degenerative disease. So that's one technique. The second technique is, again, working on the ventricular level, and since there is papillary muscle displacement, trying to bring them together. This is one technique. There are others, and there are some other minimally invasive technique for them to bring the heads of the papillary muscle together and then reduce the tethering. And since this is a class 3 type of Carpentier, and we have shortage of leaflet tissue, one last technique is to enhance or to augment the anterior leaflet with a pericardial patch. So I think we should change the algorithm of thinking and looking at the ischemic MR as a spectrum of disease. It's very complex. And for patients with LV diameter of less than 65, a tenting height of less than 1 centimeter, and a tenting area that's in this range, those patients will enjoy mitral valve annuloplasty undersized. And it will work for many years. It can work for 10, 15 years, no problem. Those who have moderate degree of remodeling, we should look into those techniques of chordal severing, papillary muscle approximation, or anterior leaflet enhancement and augmentation. Those with very large LV dimensions and very advanced remodeling, poor LV, older age, we should do mitral valve replacement if we want to help the patient. So this stage approach or anatomically-based intervention should guide us at what is the optimal operation for the specific patient. So this is a study that this approach was used in an animal model by Bob Levine's group, and this is Catherine Simansky. This was published in Circulation on an animal. This is in sheep model, and they did just what we said, a stage approach. They created an inferior wall myocardial infarction by ligating the branches of the circumflex artery and did nothing, and 3 months later they could see that there is a very significant ischemic MR based on tethering of the leaflet, and you can see the tethering angle of the leaflet. And then they did annuloplasty only, and one can see that although it improved slightly the tethering angle, there is still significant residual MR. Now they did only chordal cutting. They cut the secondary chordae in this sheep model, and you can see there is a substantial improvement of the tethering, much less MR. And when they did both annuloplasty and work on the subvalvular mechanism together, the tethering angle was the least, and there was basically elimination of the MR. Now this is an animal sheep model. Does it work in humans? And the answer is yes. This is a very tiny publication in New England Journal of Medicine. One letter to the editor, but I think it's very important. And if you can see, each one of those dot circles is a patient. And you can see that those patients, and they did the exact approach which I said, an anatomically-based intervention. So if the patient had valve tenting area and tenting height that's low, they only did undersized ring. If the patient has advanced remodeling of the ventricle with a tenting area of greater than 1.5, between 1 and 2, they did chordal severing. Here, with those only two axes, very small number of patients, when they did anterior leaflet augmentation, when the geometrical changes were advanced. So this is what they've done, and this is what the outcome on the lower panel, and you can see that the repair, the freedom from moderate MR was 92% over a period of 5 years, and 84% over for moderate MR. However, like as expected, this is a disease of the myocardium. There's no difference in survival between the repair and replacement group in this particular very experienced group from Michigan. So what we've decided to do on this particular patient, which I presented in the beginning, we've done a CABG time 3 and a mitral valve repair with a 26 millimeter physio ring, and 3 years and 3 years post-op under intense medical therapies in New York Heart Association class 2, and he's had no readmissions. And this is his echo, and his echo showed absolutely no MR. So why did I select for this patient undersized ring, knowing the limitation? Because one, he had anterior wall MI and not inferior disc in his, and you can see even in this echo that his posterior and basilar segments are functioning well. He was relatively young. He didn't have any previous intervention, and his LV end diastolic diameter was 62. Now this patient is not going to live forever because the apex, the septum, and the anterior wall are still very thin and akinetic. So his long-term survival will still be compromised, but we eliminated the MR. So to summarize, ischemic mitral regurgitation is a very complex disease with a bad prognosis. Repair with an undersized annuloplasty ring only is associated with a high recurrence rate. Failure of the undersized ring is mostly due to progressive tethering. Mitral valve repair or replacement do not improve patient survival. Mitral valve replacement has a durable effect on MR, and it reduces heart-related events and cardiovascular readmissions. However, we should not abandon repair, and mitral valve repair or replacement for ischemic mitral regurgitation should be tailored to the degree of LV remodeling. Thank you.